who came to us with unstable angina, normal LV function. His angio showed right side has insignificant disease. Left side has a LCX-OM bifurcation, Medina 111, and LAD has a 80% lesion in mid part followed by 50%. Our plan is to do LCX-OM bifurcation and LAD stenting followed by IVUS evaluation.
So here again we are going to perform distal radial puncture from snub box. I have already given local anesthesia here, and I am using just conventional 20 gauge needle with cannula, routine intracare, Gelco. Yes. Yes, set. Puncture is done.
Sanjay makes so easy.
Yeah. Thanks.
Very easy.
I had a question as to the site of puncture. Some patient or some operator like to puncture the snug box,
Yes.
little bit proximal, but I saw you like to puncture the distal portion.
Yes.
Any preference, any reason?
I think distal one is better because it is not in the cavity. So the puncture pressing is an easy job then.
Great, thank you.
You don't have to fill the cavity with the gauze piece.
So I don't know if you have the chance to
And
look.
patient is less likely to experience the pain because if you go in typical snub box, it may touch to the periosteum of these carpal bones.
You know,
I see.
is Rajiv in the room there also or no?
Is that Tejan?
Yeah.
Yes.
Is
I was-
Rajiv Gulati in the room too or not?
So Tejan, I was warned about not listening to you, so I don't know if that's true or
Oh no,
not.
I'm not talking about the procedure. You know, the reason I'm talking about that previous discussion we had here, that whether you can do this procedure without heparin or not, and everybody said that no, we should give heparin because that prevents the thrombosis in that sheath. What happens if you just transduce the pressure? That is what we routinely do. That we have double transduction, actually, transducers there. So one pressure actually is through the sheath and second one is through the guide.
You want contrast?
Yeah, but I want to make sure that the bubbles are out. Okay,
Okay.
So
perfect. Let's
I
test
think
it.
irrespective
Can,
of
can we go
that,
25 degrees LAO? 25
You can
degrees.
see that sheath.
We are
I think
ready or not?
irrespective of
There is
whether
no
you are giving-
pressure on the sheath.
Yeah, irrespective of you are giving heparin flush to the sheath or not, the concept of giving heparin is
Right, but
because,
previous discussion that the reason they said is just it thromboses the
Fine.
radial
There
artery.
we go. Okay.
Okay.
So let's take one picture in LAO caudal.
Hello, Cordell.
Yeah, the spider view, I think it's the best view to visualize the circumflex. So we're going to start with the circumflex, and I'm going to be listening to, okay, ready? To advice from the audience, including you, Tejan.
Keep it simple.
Mauricio, which one you try to do first?
So-
LED or the...
We're going to go to the circ first. So I think the picture is grainy here, but the circ is a lot more significant. Let's do an AP caudal as well. Let's go AP caudal.
Epicaudal.
Steep caudal. And then now, TAC, do you think I should do 2 wires or 1 wire into the large OM?
I think 2 wires is a good idea because it's a lesion. I think
You see now? Now you
Yeah.
can see how severe that is. So should I stent into the distal one or into the more
OM1.
proximal OM?
OM1.
Yeah.
proximal one.
Yeah, the proximal OM. So
Yeah,
that's
the
what
big
we're
one.
going to do. So
BMW.
we're going to use a BMW wire here that
Mauricio, are you planning to use 2-wire? I think there is some osteal disease in that OM2 branch. So it's
I
probably
agree
worth
with
getting
you.
the second
I
wire.
think that we're going to use 2 wires here. Sanjay was very subtly suggesting that I do that too. So I would use a double bend. Okay, so yeah.
This is pre-shaped. This is pre-shaped.
Okay, so the wires here are pre-shaped, as you can see.
So
we're gonna-
Mauricio, if there is no disease in that distal circ at the origin, you won't wire that, just stent it?
no, I don't want to stent the distal circ. I just want to stent across it, but I want
know,
to.
but if you stenting that OM, and
Yes.
if somebody tells you that circ is normal beyond that OM, would you not wire it before stenting? Still,
For protection, you mean?
yeah.
Yeah, I think so. I think we're gonna wire that.
Okay.
So which one you gonna wire first?
So we're gonna wherever the wire wants to go.
Well,
We'll take whatever. I mean, we'll be thankful. So some people say that it's not manly to use the torquer. I think I like the torquer, and I teach my fellows to use the torquer. Puff there.
You need to adjust the guide.
Yes.
So I'm against the lesion there. So
Yeah,
it seems that you guys wanted me to go to the proximal OM, I guess, and that's what I did. I just following your wishes.
they say whatever you want.
So this is a BMW wire. So it went very nicely.
Mauricio, can you talk about why did you pull that guide back?
Oh, okay, yes, because the wire had, so it's important to do this, and it's important because the guide wire was directing me towards the LED, and I didn't have enough curve in the, in the wire to reach out to the circ.
Second one.
So we're gonna get the second wire. We're gonna use a BMW too, and what I do here. So we should probably put a towel here
Yes,
to
yes.
separate the 2 wires.
Towel.
So that's the technique that I've been using because the problem is that if you don't separate the wires, then they will crisscross. They will crisscross here in the back, and then you'll push the crisscross, and then you will get stuck with your equipment when you're trying to stent or you're trying to balloon. Now you've seen the size.
That's very
of,
good trick. That's very good trick.
Yeah. So you've seen the size of the vessel, right? So what do you think? I predilate with. So it's kind of a steep bend. We'll see how it goes. I hope it works well for us.
So I don't think
How about
there's
primary
much calcium
stenting
there.
it, Mauricio?
Okay. I've not been a very good friend of primary stenting. I think that there's a little bit of calcium there. I don't think it's that soft. So, and I was warned about the Indian coronaries that they are prone to rupture. Those are exactly the words that Tejas use.
I think it's always better to predilate because it gives us a quite lot of idea regarding lesion morphology, then the calcification, and how much pressure it can withstand to dilate, and that is gives us more prediction regarding the lesion. So tight lesion like this, better to predilate.
I agree with that. So yeah, I think it's safe to predilate. So we're going to use a 3.0 by 15 balloon, if you have one, just to predilate, and we're going to go into the upper
3 by
branch.
15. Maverick.
In this, that's a problem with putting double bends is that. Okay, I think that's far
So
enough.
Fine.
So what we're going to do now, we're going to bend the towel.
Yes, on the.
So we're going to fold the towel, and we're going to
Yes.
leave. So then the other wire shows up, and we're going to work with this wire now, and that's the wire that is in the upper arm, the larger, and it's very nice to keep all your equipment wet.
A bit.
So I'm very, very lucky to work with a world-class assistant,
Thanks.
Sanjay, today. I don't think I have the luxury of work with such classy assistant. I usually work with my fellows who are.
So Mauricio, why you use 3O to pre-dilate?
Because I want to be prudent. I just want to make room, and I want to see how this is a 12, right? 3O by 12.
Yes, 12.
So I want to see a couple of things. I want to see the length of the lesion. So I think we are going to end up probably with an 18 millimeter stent, and then the second thing, I want to see how the lesion expands and what the size. If it looks too small, we'll probably do a 4.0 stent. If it looks about not that small, we'll do a 3.5 stent. And then you'll participate in the decision with me.
Are you planning to do an IVUS?
Yes, I think that was part of the plan. Okay, that's a great place to go. So we're going to go up. Oh, watermelon seated forward.
Yes.
The guide, you have to control. Yeah, go slowly. I'm holding it. Okay, you got it there. So are you going to fluorosafe?
Yeah. Mauricio, this is not a robot. So the guy will suck in.
Yeah, I saw that. I just pulled the guide. So you see that it's customary to do short inflations here in. So we're gonna go back. We're gonna pull back on the guide a little bit off there, just to see where. Okay.
We are out.
So I'm out. My sheath is also a little bit out.
Yes, fine.
So we're repositioning the guide. Okay, let's take a cine here. Okay.
Looks good.
So looks good, and the lower branch looks good. So we're gonna try to keep it simple by using one stent. What do you all think?
Yes.
Okay. So that's what we're gonna do. So let's use a 3, 5,
Or 4.
or do you want to use a 4?
Yes.
Well, let's use a 4 then. So can we see the balloon, how the balloon was inflated?
Previous view.
Yeah, 3, 5, 4. 4 is fine.
Yeah. Looks like the proximal part you need to 5.0, right?
Maybe we'll see. I mean, we can if you all want, we can also IVUS this one.
4 on the yarn.
So let's do a
4
4.0
by
by
18 to 4 by 20.
What do you want to do? 4.0 by 15? 4.0 by 15?
15 or 16.
Or 16?
16, whatever size is.
What do we have up?
Onyx is 15, so.
So this is going to be, what stent are you going to hand me? An Onyx? Onyx is great. So what has the experience been with Onyx? We just stocked Onyx in our hospital, and our experience so far has been very good. I think it's a very slick stent and it's very flexible.
Dr. Mauricio, I think there is a
Alright.
post-stenotic dilatation and there is ectasia of the artery. So,
15.
so how you are going to manage
18
that
better.
one?
18.
Let's do 18.
18.
Yes, I think there's post-stenotic dilatation there in the. So I mean the vessel is ectatic anyway. So
We can keep this
Very
two
exciting.
screen of the same size. If
Yeah.
you want to compare
yeah.
this, where sarka karte hain?
So we should.
So we can compare.
Yeah. So we should probably do a 30-second inflation
Yes.
at high atmospheres. So
So Mauricio, you said 30 seconds?
30 seconds at
30
least.
seconds?
30 seconds at least.
But TJ and Sanjay, they love to do a double. Short and double.
So what stent is that?
That's an Onyx 4.0 by 18. I mean, you convinced me. I was going to do 3.5, but I think the vote was against me. So let's take a quick cine here.
This is open.
Is it open?
Just pull.
Oh, okay.
Looks good.
Do you all like that?
Yeah.
Yes, yes.
Okay, let's go up then. Let's go up to like 16 and see how this goes. And let's stay up for
Yes, we can always compare.
Okay. Let's go to 16.
Something's good.
Looks good. I hope we can retrieve the other wire.
Yes, yes.
Okay, there's no, well, there's a little bit of ST elevation. Let's come down now. I think the size looks very good. I think it's gonna be just fine. So
Mauricio Take saying you were only 28 seconds up.
16 is 4.15.
20 seconds up.
No, you're 28 seconds.
Well, I'm getting acculturated here. Okay, let's take a cine here.
Looks
Okay,
fine.
I think it looks wonderful.
That branch is
I think the size also looks good.
No, the side branch, you need to take another angle. The osteal side branch.
Yeah, we can take a picture in the spider view.
Eloquadal.
There is
And now
T3
they'll
flow, so I won't get excited even if you see some black.
I'm
there
not
because
gonna
there
I'm
was
not
some-
gonna go after that. If anybody's thinking about that, I don't think I should go. Okay.
How about pot? You plan a potting?
Cine?
Oh,
Cine?
But Mauricio, your point is very well taken, particularly for
fine.
all the cobalt chromium stent. There was a bench study that was done by Omnistron in New Zealand, and it's about anytime when you go above 3.0 and more than 12 millimeter length, 40-second inflation really gives you the maximum stent
Yeah.
position.
yeah. So I think that this looks very good. I think we're gonna stop
Yes.
in the circ. I mean, I wouldn't IVUS. I think it looks well expanded. I mean, I think the lesion was relatively simple. I think we'll save the IVUS for the LAD. So I'm gonna pull first the wire. So this is a wire coming. So there's no problem there coming with this wire. So we're gonna pull this wire out, and we're gonna save the other wire for the LAD.
Mauricio, in case if this wire was not coming out, what would be your technique to?
So you can bring a balloon to the stent, and you can use a balloon and pull a little bit harder. If that doesn't even come, so then a technique that's been used to soften the plaque and the calcium underneath the stent is to use laser and just to zap it with laser and contrast. I don't know if you have any other suggestions, Kintur. So what I'm going to do now, so I can direct towards the LAD a little bit, I'm going to push the guiding catheter
It is
a little bit, and then I'll see. So and then we can direct the wire towards the LAD.
That's very nice demonstration.
Thank you. Just for you, Tak.
I need to ask you, what is your threshold to do a kissing for
Okay.
the side branch?
I'm not gonna kiss you, Tak.
No.
So let's go epicranial.
No, what is a threshold? 90%, 95%?
To kiss?
Yeah.
Probably when there's 95% and or a little bit of compromise in flow.
So TME2 flow?
Yeah, maybe.
Yeah, if we did not touch the side branch, there is no need to kiss for.
Okay,
One
so
more,
I think we
way
have
to-
enough wire there. So yeah,
You
let's
use
take
a
it.
micro catheter in case if wire was not coming out. Mauricio, answering your questions you asked earlier.
Say it again.
Micro catheter, in case if the wire was not coming out, bring the micro catheter all the way to the stent edge. And then
Yeah, you could do that, but then you have to touch the stent up again just to make sure that there's no deformation. So now what I was thinking is about using, because this lesion is very diffuse, I was thinking about stenting from diagonal to diagonal. Probably use a 3.0. So, I mean, we can IVUS here because we have enough room there to IVUS. Some people have suggested that, we could even do FFR. I think that the lesion is going to be significant anyway, so we're going to pull this stent balloon.
Mauricio, you think it's 3.0 there or 2.5?
I think it's somewhere in between. Looks 3.0. I mean, it's and if I go 3.0, I would probably go prudent. I would be prudent with the pressure inflation. Okay, wire is still there. I'm just used to doing this because many of my fellows will just pull the wires. Okay, so let's get there. The IVUS. So in my institution we have the other IVUS, the Volcano. Both technologies are very good. So I'm not that used to Boston Scientific, but it's a great technology. So we're going to use the automated pullback using the sledge, right? I think that, Tejan, I think that we're going to do IVUS now. We're going to have a better idea of what the size of the vessel is. So hopefully you'll be able to help me decide on the pre-dilation balloon.
IVUS I says 2.5.
Okay. You can get a show of hands there in the audience, and that can help me decide as well.
Yes.
So I'm advancing there.
Mauricio, you have
Just.
you use primarily Volcano IVUS. You mentioned.
Yes.
Because of the smaller size catheter, or is it what the technology that's inbuilt in your lab?
That's a technology that we always had in our cath lab, and the partnership we always had with Volcano. But there's actually not. I don't have any specific preference for one or the other. Actually, the Boston Scientific IVUS is the one that's being used in most of the clinical trials. If you are doing stent trials that require IVUS, you will see that. Okay, so I think that we can start.
Yes.
We can start from there. Okay, so now we're gonna start imaging the vessel. So here I think you have we're past the second diagonal, so this is perfect for us.
So 2.5 diameter.
Did we give a heparin and everything?
Yes.
Okay.
You want automatic pullback? Or?
Yeah, let's do an automatic pullback.
Okay.
So we're gonna go at 0.5. Perfect. So then you can see the diagonal coming in.
Now the disease burden.
You can see the amount of plaque there.
Some remodeling, but not too bad, huh?
Now you have circumferential plaque, and you can see there that the lesion is significant. So that's getting closer to the more proximal side.
There is good amount of calcium also.
Yeah, we're going to review again offline in a second. We're going to do the measurements. What do you think of the size, Tejan, there? So it's like 4.0 there, the ELM.
Can we check where it is?
Okay. Perfect. Okay, are we done?
So Mauricio, while you are pulling that IVUS out, you thought before that this was a very diffusely diseased artery, and you wanted to stent diagonal to diagonal. We're seeing distally the disease burden is not as bad.
Correct.
And I think distally still the vessel size is around 3.0 or
Yeah.
2.75 and
Yeah.
approximately about 3.5.
Yes, and we can post dilate with the 3.5. We can post dilate with the 3.5 the proximal part of the vessel. So let's get some measurements there. I think that's that's fine. Man, you gotta be careful because there's always positive remodeling when you have the most of the plaque burden. So it's nice to get a size in the distal edge of the plaque. So we can do it there. I mean, we can measure the minimal luminal diameter. I mean, there's a little bit of plaque there. Yeah, let's measure the minimal luminal the minimal luminal area. Yeah.
Almost 2 dots. 2
Huh?
millimeter, 2 millimeter area.
2 millimeters, yeah. And what area did he get? 1.94?
Area
Some
can
adjustment.
Yeah. And then let's see what the diameter of the vessel is at that. You're correcting it a little bit? Okay.
Where is that is measured? Is that mid LED or proximal LED?
That's, I think, the tightest. That's, well, this is all mid LED, Tejan. I think that's the tightest part of the plaque where that septal is coming off.
See, that means Indian's artery is big too. It's just disease.
Yes. Too much dosa. .6. Okay, so that's a significant. And let's see the external elastic from the external elastic membrane to just one diameter.
Visually it's about 3.5.
Yeah. Okay, now you're drawing. Okay, perfect.
It's about 3.5 in diameter.
So that's large. So what do you have? 3.5? 3.3 by 3.8? So what do you think? Pre-dilate with a 3.0 or a 2.75, Sanjay?
275.
Let's do it on 2.75 long. What's the longest balloon you have in 2.75?
275 by longest balloon.
So further into the pullback, there was some calcium if you want to see that, but it's not bad enough to really be concerned that the lesion won't respond to balloon.
I agree with you, Kintur.
So there's $1 million question, IVUS versus OCT. Mauricio, what is your opinion?
Well, I think we have a lot more resolution with OCT. I think IVUS is nice because if you can have real-time imaging, especially when there are spots that you want to identify and do and if you don't have the code registration, so you can identify and you can come back and treat subsequently. So I think that there's merit to the to both techniques, and then there's a high-frequency IVUS. I think that are improving the images.
Longest.
Quantum average 275 by 15. Do you have anything longer? Or okay, we'll use that.
Another big advantage is with OCT, we have to do multiple contrast injection, deep cannulation.
Yeah, the
That
OCT.
means
Yeah,
sometimes not visible with OCT as well. So
yeah, and then if the patient, of course, if you are concerned about the overload of contrast, then you can use IVUS instead of OCT. But the OCT is wonderful for identification of thrombus, stent malapposition, and I think the research opportunities with OCT are just tremendous, especially to study new stents, new technologies, and healing and endothelialization of the stents.
So what stent is going in?
No, we are pre-dilating, so we're going with a 275, so we're splitting the difference. So you were telling a 2.5, Tejan, I was thinking 3.0, so we're going with a 275 by 15 balloon.
Yeah.
I hope that's okay with all of you.
TJ, just
Okay,
say you're
let's
a little bit
start.
slow. He want to stand now.
Okay. Off there.
Fine.
1 second. Okay, let's take a scene there. Okay.
Yes.
So I think we're going to need, this is 15, we're probably going to need either a 30 or 34 millimeter stenting length. So let's go up there in the tightest part of the lesion. I would go to, you're at 10 now?
10.
Okay, let's wait there. So you can see that there was not too much resistance to the inflation of this balloon, although you can see half of the balloon there. Let's pull negative back, and
We need to see a full expansion. There's some calcium.
yeah, that's
there.
true. So I'm going to push the balloon a little bit, and then I'm going to come back. So let's go back up again. So we're at 12 there. Just one frame. Okay.
Looks okay here.
Yeah, looks okay. Okay, let's deflate now. So I'm going to pull back, and we're going to do another inflation just to make sure that we soften the plaque. Okay, let's go up again.
40.
Yeah, looks good there. So do you all agree that we should go to a 3.0 stent?
Yeah, I
Yes.
think so.
Okay.
3.0 post to
And post,
3.25.
yeah, and post probably the proximal part with a 15. So what stent length? 30 or 34?
34.
34. Let's do a 34 millimeter stent.
3 by 34.
That's a size that comes with Onyx.
So
Open.
Mauricio, while we are awaiting stent, have you changed your practice since after TCT for cardiogenic shock and multivessel PCI in acute MI situation? Or are you still
I'm
following
still
the
thinking about that. I'm still
guideline?
thinking about that. I'm not entirely sure, and I think I will take this on an individual basis. But the one important thing that we need to understand the management of shock. Besides that, all patients get a right heart cath. They all go to the unit with the right heart cath from the cath lab. They all go with an A line, and they all go with an understanding of what's really going on. Okay, let's see there. Okay, so we gotta come back a little bit. I mean, the length is perfect, I think. Okay, let's take a cine there
Yes.
and make sure that we are where we need to be. I think we are. I mean, I think we're being a little bit tricked by the distal edge. I think that there's a dissection. Yeah, there's a lineal dissection. So but we cannot go that much distal because proximally. I mean, I can go distal. I can put the marker just at the.
I think you're good here.
Yeah, I'm perfect there.
No,
Okay.
the proximal. What happened proximal?
We can implant
You need to put another
required.
stent?
We can put another stent. We'll see how it looks.
Okay.
Okay, so I think 3 looks generous there, so I would go to 10, 12, probably 12,
12.
just to say that we went at high atmospheres.
30 seconds?
And let's wait 30 to 40 seconds. I don't know the time.
What did you say? 12 high atmosphere?
12, well, it's not high atmospheres, but at least it's not low. It's 12. And then we'll go higher atmospheres more proximally. With we're gonna go higher size more proximally, but the size looks generous. So let's come down now. Okay, it's coming down slowly. We're going to let it deflate, and then we're going to take a picture to see where we are. And then, so I think I can safely retrieve the balloon. And now we're going to take a quick shot here. What do you think of the distal edge?
I think it looks okay. It's just.
Yeah, I think we can IVUS.
Exactly,
Looks
you
a
have
little
IVUS.
hazy, huh? Looks a little hazy distally.
Yeah, there's some plaque there,
Yeah,
I think, but it's
and,
okay.
and look at the proximal edge. I mean, unless we have a little bit of vasoconstriction, I mean, we could give a little bit of nitro,
Yes.
but I don't think we need to post-dilate the proximal part because you have a step down proximally,
Yes,
right?
yes. Nitro.
I think this is another good example that if you just purely go by IVUS and sizing, you will get in trouble.
Correct.
We always undersize a little bit. Yeah.
Yeah, so I think it's key. IVUS is going to help us here also see what's going on at the distal edge of the stent.
Nitros.
Just, let's give the 200 mics of IC nitro.
It's okay.
Okay, do you want to take another shot to see
Yes.
the effect of the nitro there? It's looking a little bit better, not entirely, or perhaps that's trying to convince myself.
Probably dissection.
Yeah.
Stent.
Yeah, maybe.
Yeah, I think IVUS will help. It just seems like a step down, honestly.
This looks
If
hazy.
if it looks very hazy, so if we need to, we can always put an 8mm, like a 2.5 8mm stent.
Your IVUS first or no?
Yeah, we're advancing the IVUS catheter now.
And if you don't see dissection there, what would you do?
Just let it heal.
Take
Probably.
everything out.
Yeah.
Yeah, even though dissection.
I would still put
depend how
258
much.
there.
Okay, so why we're doing the IVUS then?
Exactly.
I think small dissection you can leave alone, right?
You could potentially, but you
Stent
know.
thrombosis.
Yeah, that's exactly. You increase the risk of stent thrombosis there. So I need to go there with the second marker of the. Let me have a little bit more slack there. There.
Yes. Okay.
Okay.
So pull back.
Let's start pulling back. I mean, the size looks generous.
This is where volcano's chromoflow can be a little bit helpful
Yeah.
in case if there is dissection.
And then it's, you know, it's a matter of being used to one or the other technology, right? Well, the stent is nice and round, and not so round here.
Still well opposed.
No, it's good. It's good.
It's well opposed. That's
and
for
well
sure.
expanded too, about 3.5.
Yeah.
So I don't think we saw any distal edge dissection.
I didn't see any either. We
I
can
think-
take another view anyway. We can take an LAO cranial and see, and look at the proximal side. The proximal side also looks okay. I think this is a very diffusely diseased vessel, and if we try to go bigger here, we're going to end up causing a proximal edge dissection and then chase that all the way to the proximal end. You can see that this is proximal to the stent, and you can see the plaque burden in between 12 and 3 o'clock. So I think we got to stop here.
I think
maybe-
proximally MLA is really
yeah,
good.
so I would like to examine the pictures anyway. I would like to examine the pictures distally because, you know, in the first pass you can't really assess. So just So Kintur, are you using Volcano in your site as well?
Yeah, we have the inbuilt lab. In every lab we have Volcano, so we don't need
You have
a
an
console or
integrated
anything.
lab. So go back one frame, 1 or 2 frames towards the edge of the stent.
There you go.
I think that's a dissection there. Is it?
Yes, yes.
I think that there's a little dissection there.
Yeah, little bit.
At
At
4 to 6 o'clock, yeah.
Yeah. So you can see the wave there. So I think we ought to put another stent.
Yes.
You agree? I think going easy. I think that going easy, and we can put an 8 millimeter stent there, and
8 millimeter may not
Yeah.
be available, but 12 millimeter will be
or
there.
12 millimeters,
Okay. 2.5 by 12?
2.5 by 12. What do you think, Sanjay?
Yes. 2.5 by 12 onyx.
So one thing that I want to point out is that I'm working through dorsal radial axis, and even though the sheath is coming out a little bit, it doesn't feel any different than working,
Yes, we can always push in.
and we can always push it in. It has a hydrophilic coating there. Okay.
Has it?
That's a good sign. The sheath is coming out. That means that sheath is still smaller than the artery.
Yeah.
Angio
So we use it. Do you want to do an angio?
another angle? Or
No, we don't need another angio. So I think so in my place, the fellows have forced me to use a tegaderm. So we just got used to using a tegaderm just to maintain the sheath in place.
Sanjay, which all cases you take distal radial puncture?
Majority cases means we don't have any
Okay.
particular preference where dorsal radial is to be taken or regular radial.
Mhm. So hopefully the stent will go.
Yes,
The wire is a little bit deep. I'll pull on the wire a little bit.
guiding is on.
We got the guide. Angioplasty 101, so get your guide in place so you can push. I mean, the cine pictures are so amazing here. I think we have enough overlap there to go. What do you think, Sanjay?
Little
Let's
bit,
take a
little
cine
bit.
there. Yeah. I think it's good. What do you guys, what do you all think?
It's excellent. Go.
Okay, let's go.
Go.
Have enough overlap, approximately?
10,
I would probably go to 12, 14.
12, 14.
14, yeah. Yeah. And it looks nice and tapered. So the other thing that I would do, I think we can come down now. So we're going to pull back slightly, and we're going to do an overlapping inflation at high atmospheres. So let's crank it up to 18 there. Perfect. Hopefully we'll be done with the case. Okay, let's come down now. Okay, so this is a moment of truth now.
Sure, that is fine.
I think it looks nice and clean. I think
Beautiful.
we're gonna go ahead and pull the wire. Okay, do you want to take do you like to take pictures without the wire?
Yes,
Let's
yes,
take
yes.
a couple of pictures now. Oh, shit, that's my bad.
Okay.
Okay, let's do it. Excellent. And then
Excellent.
let's do now an AP caudal,
Yes, epigordal.
just to
Center. Okay. It's good.
looks very good. Any comment about, let's go back one shot about the proximal LAD. Let's go back. One shot.
Previous-
Any comments about the expansion? I think by IVUS everything looked very good. There's plaque proximally that we're not going to be treating because it's not significant. I think we can safely conclude the case.
Yes.
Thank you so much. I want to thank everybody for the
Very good.
opportunity, and this is a wonderful cath lab, one of the best I ever worked in.
Okay.